Welcome, Dr. Moores.
Thank you everyone for joining us tonight and participating. We'll be talking, as Rosie mentioned, about women and epilepsy. And the brief kind of structure of how we'll go through things for today is we're going to start just talking briefly about hormonal changes and how it can affect women with epilepsy. And then more so starting at the beginning of a woman's life cycle, starting with contraception, then talking about pregnancy and ending with menopause and bone health. As Rosie mentioned, if you have any questions, you can put in the group chat or save them for later. And certainly we can do our best to go through them all at the end of the presentation. So every month, our bodies prepare for the possibility of pregnancy. And as our bodies do that, we go through monthly hormonal cycles. We know that the levels of hormones, mainly estrogen and progesterone, cycle each month. And in this picture, we can see estrogen being the pink color and progesterone being more the orangey red color. The normal menstrual cycle is considered to be 28 days, with week 1 being the first week of the menstrual period and ovulation occurring mid-cycle when an egg that's ready to be fertilized is released from the ovary. After ovulation, estrogen drops while progesterone levels increase. If fertilization of the egg does not happen, levels of both estrogen and progesterone drop off completely, and then you have your menstrual period. And the reason that this is important is because hormones can affect the brain and they can affect seizures. We know that estrogen is excitatory, meaning that it excites the brain and makes seizures more likely to happen. And conversely, progesterone is inhibitory and makes seizures less likely to happen. Some women may notice a pattern of seizures related to the menstrual cycle. And when we see that pattern, this is what we call catamenial epilepsy. There can be 2 patterns observed. The first type is when seizures occur more often with menstruation, whereas the second type, seizures occur more often with ovulation. Between the 2 types, the first type is more common. Oftentimes, women with a pattern of seizures related to their menstrual cycle have more PMS-related symptoms, and it can be helpful to use a phone or a calendar app to track your seizures and see when your seizures are more or less frequent and try to identify any sort of triggers, provoking causes that may be kind of related to your seizures, one of which may be your menstrual cycle. Certainly, if we do see this pattern of what we call catamenial epilepsy or seizures related to the menstrual cycle, the treatment plan for your seizures can actually be tailored specific to this pattern observed. So if you do notice it, it's helpful to talk to your neurologist or epileptologist about that. There are lots of different methods of birth control available these days, and certainly the oral contraceptive pill remains one of the most common methods. When we think about birth control, we like to think about effectiveness as well as how it works. And so the most effective method, aside from abstinence altogether, would be what we see at the top of the picture. So it would either be the IUD, which is a device placed in the uterus, or more formal vasectomy, tubal ligation, a more surgical procedure to prevent pregnancy. And those are the most effective options. The pills, the ring, the patch, and injection methods are all hormonal-based methods, meaning that they deliver small amounts of hormones to prevent pregnancy. While these methods are good options, they do have potential for errors in the sense that you can forget to take a dose or might take the dose at the wrong time, which increases the chance of getting pregnant while on these methods of birth control. Lastly, we have barrier methods, such as condoms, diaphragms, which can be used as well for birth control, but have much higher rates of failure and pregnancy on these methods. And we know that seizure medications, some of them increase the ability of the liver to break down hormones And by doing so, they increase the risk of oral contraceptives not working because they break down the hormones that are contained in the oral contraceptives. This means that the failure rates for the oral contraceptive pill and some other hormonal methods can be significantly higher for women with epilepsy on certain anti-seizure medications. And so in some cases, we recommend that a backup method or a second method of contraception be used for women with epilepsy taking the oral contraceptive pill and certain seizure medications. It's not the case for all seizure medications, but it is important to discuss any possible interactions with seizure medications and contraceptive method with the physician. Additionally, the estrogen component in hormonal contraceptives can cause the body to break down some seizure medications. Most commonly, we see that with lamotrigine and valproic acid. And what this can mean is typically for the oral contraceptive pill, there's 3 weeks of hormone week and then 1 week of sugar week or placebo week where there's no hormones being delivered. And so because hormonal contraceptives can break down some of the seizure medications during the 3 weeks where you're getting hormones, it may make seizure medications less effective. And conversely, during the sugar pill week, the amount of seizure medication in your blood might increase and causing side effects. So the question is, what can you do? It is important to have this discussion with your neurologist or epileptologist and let them know, are you on any form of contraception, what you're taking, and if you make any changes to it, just for them to also be aware so that they can monitor your seizure medications and just counsel you on do any changes need to be made. Certainly, if there's major issues with interactions, sometimes we can look to change the seizure medication because, as I mentioned, certain seizure medications have more interactions with hormonal contraception and some have less. And so medications like brivaracetam, clobazam, gabapentin, cosamide, levetiracetam, pregabalin are all less likely to cause any sort of hormonal failure. Sometimes what we can also do is change the contraception used. So as I mentioned, the intrauterine device is one of our more effective contraceptive options and typically has little interaction with any of our seizure medications. For other people who do require the oral contraceptive pill or injections, sometimes we use 2 methods of contraception just to really protect against unplanned pregnancy. So sexual relationships are a normal part of healthy living, and multiple things can lead to sexual activity. It includes a desire for sexual activity, arousal, the need to have sex, and an orgasm, which is the height of physical pleasure during intercourse. And these processes depend on many steps that are coordinated by the nervous system, and it involves hormones, nerves, blood vessels. Sexual desire itself varies widely in the normal population and is a very personal matter. And so as long as you are satisfied with your level of sexual activity, there really is no problem. The reason I want to bring this up, though, is that we know that some seizure medications and epilepsy itself can affect sexual dysfunction and sexual arousal. And so there can be things such as psychosocial factors, anxiety about having a seizure during intercourse, as well as concerns about like expressing or relaying the diagnosis to a partner. We know that some seizure medications and seizures themselves can affect regions of the brain involved in sexual function. Mood disorders can be more common among women with epilepsy, and that can also affect sexual function. And so, although it's quite difficult to have this conversation, it is important to talk to your doctor about any sexual difficulties that you may be encountering. While these can be very private and personal issues, it is important to share these openly with your doctor so that they can better understand and really help you. In addition to just seizures and seizure medication, there are actually many other causes of sexual dysfunction, and they can be treated very differently. And so if you are worried, just have the open conversation with your doctor so they can assess for maybe the reason why and see if there are any ways to help fix it. I'm not certain if the pediatric to adult neurology transition is as relevant for this group today, but in case we have some younger participants with us, we'll go through this briefly. And so when you become 18, you legally become an adult. There's a lot of benefits, including increased responsibility, a transition to the next stage of your life. However, it's also a big transition period for your health. You're required to give permission for a doctor to speak with your parents to discuss your medical condition if you would want. And it can be stressful. And so I just wanted to address some concerns to help you or to help anyone more independently manage their epilepsy. And certainly it applies to all individuals with seizures, not just individuals transferring from pediatric to adult neurology. Certainly, we know that some medications, which are very good for seizures when you're younger, aren't preferred at older ages. Similarly, the way medicine is advancing these days, we're developing newer and newer seizure medications, sometimes which have less side effects compared to the older medications, or don't need drug monitoring, or have less medication interactions. It's always helpful if you're seeing another doctor for the first time or transitioning to another neurologist to know the names of the seizure medications that you've previously tried and the reasons why you no longer take them, whether it's side effects, it didn't work for you, or a decision was just made to switch. Certainly, it helps us better understand your seizures as well as helps inform any sort of treatment decisions in the future. Maintaining healthy life choices to keep your epilepsy under control is always important. And so those are things like everyone is aware of: maintaining a good sleep schedule, avoiding drugs or excess alcohol, which can lower the seizure threshold. Some people may have medications that they're given during long seizures or clusters of seizures, and that's something we call a seizure action plan. And so if you're someone who tends to have longer seizures or clusters, it's important to have some sort of plan and let other people know what they can do in case you do have a seizure so that they can be ready to help you. Medical insurance is always a challenging discussion to have, and certainly something we don't like to talk about often in Canada, but it is important. Seizure medications vary greatly in terms of the cost, as well as coverage by both private insurances as well as through ODSP or the CPP plan. And so it is helpful that if there are concerns about cost or even medication coverage or switching insurances, that you have an open discussion about it, just to ensure that we can maintain you on a seizure medication regularly that is affordable and easy to access. Certainly, it's better to take a medication regularly as opposed to taking it inconsistently because of cost or insurance issues. So we'll move on to talk about pregnancy, and this might be the most common question I get asked, and it's always, are my chances of getting pregnant affected by my seizures or my seizure medications? And overall, out of everyone in the United States, about 6% of women have infertility issues. Older studies used to report that women with epilepsy had about 15% fewer children. But it's important to note that those are birth rate statistics. And so that doesn't translate directly into fertility because it doesn't take into account people who simply choose not to have children or because of other factors. And so more and more, as we examine these older data, we see that there's actually many reasons why so many more women with epilepsy didn't have children historically compared to other overall population. There can be effects such as choosing not to become pregnant. Previously, there were actually recommendations that women with epilepsy should not become pregnant that affected that. Some seizure medications can have effects on ovaries, which can affect the ability to get pregnant. And then, as I mentioned before, menstrual irregularities because of seizures themselves. However, what's very important to note is that more recent studies that have controlled for people who choose not to get pregnant or other kind of social factors have actually shown that there's no difference in fertility rates or the time to conceive among women with epilepsy compared to just normal healthy controls. And so this chart or graph that we can see on the right side of the screen, the neon blue line are women with epilepsy, and the dark blue blackish line are just normal healthy women. And what they looked at is from the time that contraception was discontinued to the time that they got pregnant. And as you can see, that there's almost no difference in terms of time to conceive or pregnancy rates between women with epilepsy and healthy women after they discontinued contraception. Reassuringly too, most women with epilepsies have completely normal pregnancies. However, there are some unique considerations that are unique for women with epilepsy, and we do like to talk about those. There can be an increased risk of seizures during pregnancy, changes to medication, as well as monitoring for mood effects. And so we'll talk a bit more about this in the next few slides. But I just want to point out and really highlight the fact that most women have normal pregnancies. One of the next most common questions I am asked is, can I pass epilepsy on to my child? And overall, there is some genetic susceptibility for developing epilepsy. However, overall, the risk is quite low. So in the general population, amongst everyone, there's about a 1 to 3% risk of developing epilepsy. Among children born to women with epilepsy, that risk is slightly higher at about 2.4 to 4.6%. So it is higher than the general population, but overall quite low. We do know, though, it depends on the type of epilepsy you have as to that risk. So there are some rare, less common epilepsy conditions that are related to mitochondrial disorders, autosomal dominant nocturnal frontal lobe epilepsy, or autosomal dominant temporal lobe epilepsy, which can carry a higher risk of inheritance, whereas most other acquired epilepsies, which are secondary to trauma or some sort of injury sustained as an adult, carry a much lower risk of developing epilepsy in the child. But overall, between all cases, the risk is low. The epilepsy pregnancy registries are prospective studies that look at the risks of seizure medications, any sort of birth defects, or major adverse outcomes among women with epilepsy who get pregnant. And these pregnancy registries are where we get a lot of our data from, just because pregnant women are never included in scientific randomized controlled trials, or rarely. All these epilepsy pregnancy registries, you can self-enroll. So you actually don't need a doctor to enroll into this. You can go onto their websites and you can self-enroll, and they ask you questions about your seizures, the types of seizures you're having, what medication you're on, and they gather data from you at different points throughout your pregnancy and postpartum. In North America, we have the North American Pregnancy Registry, but there's also a similar one that exists in Europe and the United Kingdom, in Australia, and then the Kerala Pregnancy Registry is in India. And thanks to these registries, we have a wealth of information that we never had before. We do know that among all babies, there is a risk of about 1 to 3% of baby having a major kind of birth defect. Among children who are born to women with epilepsy, this risk is slightly increased. And we think that this is owing to seizure medication being passed through the placenta from mom to baby. These can include things like low birth weight, certain problems with organs forming properly, and even less cognitive problems. But the risk is really specific to the type of seizure medication used for seizure control. And there's quite a bit of variation of the risk based on which medication a mother is on. in general, we prefer
Just
lower doses of medication and being on the least number of seizure medications that work to control your seizures. We know that lamotrigine, levetiracetam, oxcarbazepine, I would say are top 3 preferred medications for seizures in pregnancy because they carry the lowest risk of any sort of problems with baby. Valproic acid is one of our older seizure medications, and while it works very well for seizures, it carries by far the highest risk of a problem with organs forming, especially with closure of the spinal cord and cognitive issues. And so generally we try to avoid pregnancy on valproic acid when possible, but certainly in some circumstances, it's just not possible because that is the medication needed to control someone's seizures. Some of the newer seizure medications, unfortunately, we don't have much safety data for, and the registries are working to try to gather that information. And so some of these newer medications include glucosamide, brivaracetam, perampamil, eslicarbazepine, refinamide. And for those ones, it's a case-by-case, person-by-person basis to discuss with your neurologist or epileptologist what should be done in the setting of pregnancy. The question is really, what can you do? We know that 50% of all pregnancies are unplanned. And we do recommend that all women of childbearing age who are on seizure medications take folic acid. And typically the recommended dose now is 0.4 to 4 milligrams a day. And that's because a lot of major organs in development occurs very early on after conceiving and typically before a woman knows that she's pregnant. We know that folic acid can reduce the risk of birth defects and especially spinal cord problems. And as I mentioned before, some seizure medications can increase the risk of those problems developing. And so therefore we think that by giving higher doses of folic acid, we can decrease those risks. Before, and certainly anyone who got pregnant a number of years ago, we used to give very high doses, 5 milligrams and beyond for all women. However, more recently, there's been more data to suggest too much of anything is never a good thing. And so we've lowered those numbers down to, with the recommendation being 0.4 to 4 milligrams a day. If you are on a prenatal vitamin, it's important to check because most over-the-counter prenatal vitamins that you buy at the drugstore, the grocery store, have a lower level of folic acid than typically recommended for women with epilepsy. And so it's important to either get a special one, which in Canada is typically called Pregvit, or to supplement using additional folic acid if needed. We always recommend maintaining a healthy lifestyle, and that's just a general recommendation. So things like avoiding smoking, maintaining a normal weight, having a good diet. The goal is always to try to be seizure-free prior to pregnancy, because that certainly helps to predict seizure freedom during pregnancy. When possible, try to consult your neurologist before you get pregnant, so that a physician can help make any changes to your medication in order to maintain seizure control while remaining on the minimum number of low-risk seizure medications. And while we always try to do this prior to conceiving, if you do get pregnant on seizure medications, it is important not to make any changes to the seizure medications yourself, because we don't want to start or stop anything abruptly, which can have side effects themselves and risk worsening seizures. So seizures themselves, typically there is no change in seizure frequency during pregnancy. However, there are a number of risk factors for potential seizures. So because of the hormonal changes that happen during pregnancy with estrogen and the progesterone that I previously talked about altering and having higher levels of hormones in the blood, some seizure medications can be cleared through the body quicker. And so the blood drug levels of the medication can be cleared through quicker. And so we sometimes need to make dose adjustments during pregnancy. Furthermore, stress and sleep deprivation are very common triggers for seizures, both outside of pregnancy and inside, and those factors can play a role in pregnancy just because factors like comfort, back pain, they can all affect the ability to sleep, as well as the excitement, as well as the increased period of stress. And then furthermore, the hormonal changes, as I mentioned before, can change the tendency or likelihood of seizing. However, recent data has shown that as long as you are closely followed by a specialist, pregnancy itself does not increase the risk of seizures. And so it is important to make sure you have a specialist who you can follow closely with, as well as once you know that you are pregnant, to let them know so that they can arrange for closer follow-up. And typically this occurs anywhere from once a month to once a trimester during pregnancy, which is much more often than most people see their physician. So we've spoken a lot about the risks of medication during pregnancy, but I just wanted to highlight too that it is important to note that seizures themselves carry a risk, and this is why we have to balance the risk of medication with optimizing seizure control. We don't recommend stopping all medications during pregnancy because there are risks of seizures themselves. And although the risk is low, seizures can harm both mom and baby. And so there's things like trauma, especially if there's loss of consciousness during a seizure, any abnormal movement, and that can hurt mom and baby. We know that certain types of seizures can increase the risk of premature labor or miscarriage during pregnancy, as well as when a seizure is happening, there can be decreased baby's heart rate. And as I'm sure everyone's aware, seizures that affect level of awareness or level of consciousness have implications to driving. And even if those seizures occur because of the pregnant state, it does affect your ability to drive, and the Ministry of Transportation is involved. So it is important to make sure that you're taking your medications regularly and you're getting good sleep to decrease the risk of seizures in pregnancy. That's not to scare anyone. Certainly, like I said, most pregnancies go well and have no concerns, but it is important to be followed closely. As I mentioned, some seizure medication levels must be checked during pregnancy, and this is especially true for lamotrigine, oxcarbazepine, and levetiracetam, because those medications are the most commonly used medications for women during pregnancy because of their safety profiles. But we also know that those medications are often cleared through the body much quicker because of the pregnant state. We may need to adjust doses of medications just to maintain similar levels of the medications in your blood as before pregnancy. However, any dose adjustments that are made during pregnancy typically are adjusted after you deliver, just to avoid any sort of side effects. I think I was muted for a bit of that, so I'm not certain what I missed, but
just one sentence. My
oh,
bad.
okay. Perfect. Yeah, so any doses increased during pregnancy need to be adjusted in postpartum. Otherwise, you can develop side effects with the higher doses. But most important is keep taking all medications as prescribed by your doctor, and don't make any medication changes yourself without consulting them first. During pregnancy, mood swings are very common, and it can happen for a number of reasons. It can be fatigue, not sleeping enough, changes in metabolism, hormonal changes. But women with epilepsy are at increased risk of mood swings during pregnancy. And so it's really important just to have an open dialogue with your family, friends, doctor about any mood changes you might be noticing, just so that they can support you and help you get any sort of help if needed. Another common question is, do I need a high-risk obstetrician? What about a midwife? Can I deliver? And so we always recommend a multidisciplinary team. And for everyone, it looks different, but typically the common players involved would be a neurologist with a special interest in epilepsy and pregnancy, an obstetrician, and typically this is a high-risk obstetrician, if you live in an area where that's available. There can be a midwife who helps with kind of prenatal care, an anesthesiologist, as well as nurses and some other healthcare providers. From an epilepsy perspective, a vaginal delivery is safe, and typically we reserve C-section for if there's problems with baby or an obstetrical indication, or if it's the patient's preference. We do advise, though, to give birth in a hospital. And that's because from my perspective, the main thing that's indicated for labor and delivery is an epidural. And the reason we do an epidural is, especially with kind of a first pregnancy and a first child, typically is the longer labor. And so with an epidural, there's less pain. Typically, mom is able to get some sleep during labor, and therefore it decreases the chances of breakthrough seizures. Certainly from my perspective, if there is the event of a seizure during delivery, being in a hospital is a better place to be, because there's all the resources and team members available to help if needed. I do recommend, though, whenever going into a hospital, whether it's for labor and delivery or if you're just going in for routine surgery, I do recommend bringing any seizure medications to a hospital with you, because some of the seizure medications are more unique and not commonly available in all hospital areas. And so it's important just to have your own medications with you in case you need to keep taking them regularly, or in case they're not available when you need them. We already touched upon it, but touch base with your doctor, as any medication changes made during pregnancy typically need to be altered postpartum. Oftentimes we target a slightly higher dose than pre-pregnancy dosing, just because we know that, as even with the best of family supports, there is a bit more stress and there can be more sleep deprivation postpartum. And so we just try to protect you a bit more with the plan of eventually getting you back to your full pre-pregnancy dose. Again, monitor for your mood and any signs of postpartum depression, because this is very real, and certainly you can benefit from psychotherapy and even in cases antidepressant medications to help with those mood symptoms. Meditation and relaxation techniques can also be very helpful if you notice mood changes. And then there are safety considerations, and I'll just talk a bit more about that. So importantly to note, without a healthy mom, there is no healthy baby. And it's common that new mothers try to do everything they can to put baby first, but sometimes it's important to take a step back and prioritize yourself. We discussed that considering new mothers might be sleep deprived, especially within the first few months of their delivery, they can be at higher risks of seizure during that postpartum period. And so I do recommend having an adequate stretch of sleep, trying to average 8 hours in a day. And in order to achieve that, sometimes she might need support from her family. Maybe one of the family members takes care of one of the nighttime nursing so that she can get a longer stretch of sleep at night, especially considering that baby tends to wake up frequently during the first month of his or her life. Other safety things can be avoiding sleeping with baby. That is a general recommendation for all mothers, but especially women with epilepsy. In case of a seizure in bed, you wouldn't want to accidentally roll onto baby. In general, we prefer showers to bath for anyone with epilepsy. And usually I recommend keeping kind of bath time for baby as a family activity with the presence of another adult present, in case a seizure were to happen while bathing baby, that someone else who could help both mom and baby, as opposed to baby being left in the water. Other things that can be important are keeping multiple change regions in the house and close to the ground, rather than on a high-rise bed or change table. In case there's a seizure, we don't have to worry about baby rolling off a high surface. as well as making sure all medications are childproof, especially as children get older. A common question I get asked is, can I breastfeed? And so in general, breastfeeding has many advantages. It can improve baby's health by providing important antibodies. It decreases the risk of infection. It contributes to the maternal-child bonding during the early months. And many women find that breastfeeding is a very important component of their maternal experience. Some studies have found that there's really no kind of adverse effects of breastfeeding infants while taking seizure medications. And in fact, one study found that breastfed children of women with epilepsy had higher IQ scores than children born to women with epilepsy who did not breastfeed. So certainly from my perspective, the benefits of breastfeeding generally outweigh the risks, and I do support breastfeeding. During breastfeeding, certainly you will be on the medication and baby will be exposed to mom's seizure medication, but overall this amount is small and less than the amount that they were exposed to while you were pregnant. As with pregnancy, we always try to breastfeed at the lowest level of medication, if possible, taking medication during the child's longest sleep interval so that you're at the lowest level of medication while breastfeeding. I always tell parents to observe the infant, monitor for any signs of drowsiness, poor suck, irritability. If those do happen, see your pediatrician or family physician. Most of the times, this is completely unrelated to being on any seizure medication, and it's related to reflux, normal baby experiences, infection, and certainly they would be the most appropriate provider to assess for it. But I do say, let them know that you are breastfeeding on seizure medication, because if there are concerns that it is the seizure medication causing any symptoms, we can check medication and seizure medication levels in babies similar as we do adults. So moving on a bit to the later stages of life, menopause is the time of life when a woman's ovaries stop producing viable eggs and cycling. Typically it occurs around age 50, but it varies quite a bit from individual to individual. During menopause, there's changes in hormones produced by the ovaries, both estrogen and progesterone. And we talked about how they can affect seizures. And so we can expect changes in seizure frequency around the time of menopause. The relationship, though, is a bit more complicated. We discussed how estrogen increases the risk of seizures because it's excitatory, and progesterone decreases the risk of seizures. During menopause, levels of both hormones can decrease, and so the net effect is actually quite challenging to predict. Overall, there is really no significant change in seizure frequency with menopause. However, women with the catamenial pattern of epilepsy, where the seizures are related to the menstrual cycle, can have an increase of seizures during the perimenopausal period, where periods are irregular and coming sporadically, but long-term after menopause can see a decrease in seizures. But for most other women, there's really no change. Hormonal replacement therapy is commonly used for most women, and it can release some of the symptoms of menopause, such as hot flashes, vaginal dryness, poor sleep. There are many different formulations of hormonal replacement therapy, each of which have varying amounts of estrogen, progesterone, and progestin. We do think that hormonal replacement therapy can help prevent osteoporosis, which is a thinning of bones. However, certain types of hormonal replacement therapy can also increase the risk of stroke, breast cancer, and uterine cancer. We no longer recommend hormonal replacement therapy to decrease the risk of heart disease. And really the decision to use it is made on a case-by-case basis based on individual factors and symptoms present. From the epilepsy perspective, hormonal replacement therapy containing mainly or only estrogen can worsen seizure frequency, whereas progesterone containing hormonal replacement therapy is less likely to compromise seizure control. And so that's generally the preferred method if needed. We do know that women with epilepsy are at higher risk of osteoporosis, and hormonal replacement therapy can help to prevent it. However, it's always important to discuss with your doctor whether or not it would benefit you, but also there are non-hormonal alternatives to treat symptoms of menopause, one of which includes gabapentin, which is also a seizure medication and therefore can provide dual benefit for both symptoms of menopause and seizures themselves. As I mentioned before, osteoporosis is a thinning of bones, and we see it more commonly as people get older, and women are overall more affected than men. Women with epilepsy, furthermore, are at a higher risk of adverse bone health, even at younger ages, and it can be related to certain medications that increase the risk of kind of bone turnover and thinning of the bones. The common ones that we see are some of the older medications, including phenytoin, phenobarbital, primidone, carbamazepine, and valproic acid. But the risk is higher when you're on multiple seizure medications or on medications for a longer period of time. Osteoporosis can be dangerous for women with epilepsy if they fall, because it can lead to increased risk of fractures. And so in general, it's important, if you've been on seizure medications for a long period of time, to discuss this with your family doctor. Is certainly we recommend bone mineral density screening, just to check for bone health. What can you do to help with your bone health? I mean, exercise is important and probably the best bone protection we have. It's important to engage in weight-bearing exercises, meaning that you're working against gravity. So examples of this can be running, playing tennis, stair climbing, dancing, martial arts, anything where you're upright, standing, and kind of working against gravity. Eating a well-balanced diet is important for overall health, but in general, we recommend at least 1,200 milligrams of calcium daily and 1,000 units of vitamin D daily. And so some calcium-rich foods can be dairy products, but also green leafy vegetables, and vitamin D-rich foods being fatty fish, fortified milks. Certainly, if you're not able to get enough of calcium and vitamin D in your diet, supplementation with vitamins can be important as well. And so that kind of concludes the part of the presentation I wanted to discuss. So we've discussed some of the unique challenges and consideration for women with epilepsy. We talked about how hormones can impact seizure control through many different stages of life, and that family planning is important for women with epilepsy, but that epilepsy is certainly not a contraindication for pregnancy, and that most women can have healthy pregnancies with good seizure control in pregnancy.
Thanks to Dr. Moores for such a excellent presentation.